Assalamu alaikum. Good evening, ladies and gentlemen. It's my pleasure today to be a part of the Saudi Society for Blood Disorder webinars. Please, if you follow us on Twitter, and you can see all of our videos through YouTube. We're pleased to announce the MENA Challenging Cases in Hematology 2020, which will start from today and 7th of September. We're having an interesting case each month. During COVID time, most of the teaching and webinar were shifted through audiovisual. So we have chosen some interesting topics for you, like Langerhans histiocytosis for today, Waldenstrom next month, plasma cell disorder on 20th of October, and amyloidosis 30th of November, and graft-versus-host disease 14th of December. We're glad to have national as well as international speakers for each topic. So first, would like to thank our sponsor, Platinum sponsor by Janssen and Golden sponsor by Hikma, for supporting our webinar, the MENA Forum for Challenging Cases in Hematology 2020. So today I'm glad to introduce our first speaker, Dr. Carl Allen. He's an associate professor of pediatric hematology oncology at Texas Cancer Center. He's a co-director of histiocytosis and lymphoma program. He's also an author of How I Treat Langerhans histiocytosis, which was published in Blood 2015. He has over 98 publications, and he has an interest in histiocytic disease, including Langerhans cell histiocytosis. Also, we have Dr. Ghaleb Alyamani. He's a hematopathologist from Prince Sultan Medical Center, who will talk about challenging cases on diagnosis. So
first identified. And I put this picture here to demonstrate that sometimes people talk about low-risk LCH as not being a major issue. But you can see here that this is a patient that presented to us with lung and pituitary involvement. After almost a year in the ICU with dozens and dozens of chest tubes, she recovered from her disease, which I'll show here in the next slide. So you can see that managing pulmonary LCH is really a mechanical problem early on, but that with chemotherapy and full recovery, this patient really remodeled her tissue quite beautifully, and now is a 7-year-old who's doing quite well. So again, I think some of the complications about understanding what LCH is and where it comes from arises from differences in interpreting what kinds of patients we see. So Christian Schuler kind of represents case reports and case series from the early 1900s of patients who had bone disease, maybe exophthalmos and pituitary disease. Letter Siwi is the high-risk LCH. Orthopedic surgeons still frequently refer to LCH as eosinophilic granuloma, and there's some other forms that are discussed specifically. But in the 50s, Lichtenstein and some other pathologists noted that no matter which of these conditions the biopsy comes from, they look more or less the same under the microscope. You see these reniform dendritic cells with inflammatory infiltrate, and they proposed a new nomenclature of histiocytosis X, X meaning we're not really sure what the cell of origin is. And we'll hear more about this later, but again, you can see these coffee bean-shaped nuclei among an inflammatory infiltrate. They stain positive for Langerhans or CD207, for CD1A, and there can be a blush of FASN and factor 13A, which typically are used to differentiate LCH from other non-Langerhans cell histiocytoses. Sorry, when the chat goes on, I have a hard time advancing this. Okay, and so this is an electron microscopy demonstrating another characteristic feature of LCH, which is this Burbeck granule. Burbeck granules are associated with Langerhans and are thought to be involved in kind of attaching to antigens and then processing them for antigen presentation. This is a feature shared with epidermal Langerhans cells. This was discovered in the 1970s. And because of this discovery, the only other, because the epidermal Langerhans cell was the only other cell known to have Burbeck granules, it was presumed that LCH, or that histiocytosis X arose from some sort of dysfunction of epidermal Langerhans cells. Hence, we have the name Langerhans cell histiocytosis. So to understand LCH, we have to understand Langerhans cells. We're going to go back to the 18th century, where Paul Langerhans was really this clever medical student working in Virchow's lab, and he was staining all kinds of organs with gold colloid. And when he stained skin, he noticed these cells that really looked like perhaps axons. And so he wrote his thesis on the nerves of human skin, kind of presuming that LCH arose from epidermal Langerhans cells. I'm sorry, he thought this was sort of a nervous network within the skin. And so these cells have subsequently been discovered to be dendritic cells or immune cells, but he still gets credit for discovering them. As we've learned more and more about autogeny, I think this is really important for us to understand LCH. So normal epidermal Langerhans cells come from very, very early in fetal development from the embryonic yolk sac during this first wave of tissue macrophages. And that's an important thing I'll come back to a little bit later. So what had been presumed was that LCH arises from some sort of inappropriate stimulus or transformation of this epidermal Langerhans cell. And that's where we get into discussions about, is this an autoimmune disease or is this a cancer? All right, so now we enter the modern era. So when I first came to Texas Children's Hospital, Ken McLean had acquired quite a large clinic of patients with LCH, and we just been able to start doing biopsy collection and some flow cytometry where we could sort the LCH lesions. And so for my fellow thesis project, we just wanted to ask a very simple questions. Well, what do these LCH Langerhans cells look like compared to epidermal Langerhans cells? And we were quite surprised to find that based on very simple Affymetrix gene expression data, that the LCH CD207 positive cells had a lot of these features, CD11C, CD11B, et cetera, that really seemed to suggest that they were less differentiated than epidermal Langerhans cells. And so if LCH arose from epidermal Langerhans cells, that didn't make a lot of sense. So at the same time, when we were analyzing the difference between LCH lesions and these epidermal Langerhans cells, Mir, Murad, and others were studying ontogeny of various dendritic cells. And what was discovered was that, in fact, there were all kinds of cells that could eventually express Langerhans, whether they arrived from the yolk sac, from the bone marrow, from monocytes, from dendritic cells. And so Langerhans is much more promiscuous than initially thought. Therefore, LCH can arise from many more different types of cells. Another major advance in LCH was the discovery from Barrett-Rollins group at the Dana-Farber that 57% of LCH lesions had the mutation of BRAF V600E. And in all cases, it looks like the MAP kinase pathway was activated with phospho-MEK and phospho-ERK being activated. So just very briefly, cells that express tyrosine kinase receptors, when a growth factor binds those, they transduce the signal through RAS, RAF, MEK, ERK, which then elicits a cell-specific transcriptional pattern. In the case of BRAF V600E being activated, that pathway is on all the time. It becomes constitutively active, and the consequences depend on the cellular context. So after Barrett-Rollins discovered BRAF V600E, we went to our freezer. We had 100 cases of LCH where we had frozen the peripheral blood or bone marrow down. And we also had matching LCH lesions. And we found that in 63% of the cases, we were able also to find BRAF V600E. And like Barrett, we didn't find any association with high risk, low risk, et cetera. So it seemed to not really confer clinical significance in our cohort, except that patients with BRAF V600E relapse at a much higher rate. And in fact, in a national French cohort, they in fact found that BRAF V600E was associated with higher risk disease as well. So when we went to the blood of the patients who had LCH, we had kind of a surprising finding. We were able to take advantage of a very high sensitivity BRAF V600E PCR primer series. And when my lab tech was doing these experiments, we found that in some cases we can detect BRAF V600E in the blood, but in other cases we couldn't. And at first this seemed kind of random, but then when we lined them up based on the degree of disease, we found that the high-risk patients, we could always detect BRAF V600E in the blood of patients from BRAF V600E positive lesions, rarely in case of multifocal low-risk disease and never in cases of non-risk single lesion disease. And when we asked the question, where do these mutations come from, we found that they localize into the myeloid compartment in CD11C and CD14 cells. We didn't see them in plasmacytoid cells. When we went all the way back into the bone marrow of CD34 positive cells from bone marrow aspirate, we also detected BRAF V600E mutation in a large number of cases, demonstrating that this mutation can arise very, very early. So again, working with Miriam Murad's group, we tried to model this observation in mice. And so the first thing we did was try to enforce expression of BRAF V600E in Langerhans cells. And what we found was that it didn't really confer much of a phenotype. However, when we expressed BRAF V600E and CD11C cells, you see in that circle, it's monocytes and myeloid DCs, we were able to get mice that actually had quite a significant phenotype that looked a lot like high-risk LCH, big spleen, big liver. They die young, and they express Langerhans. So based on this, we come up with a model that we think that LCH really is a disease of hematopoietic differentiation. So in patients with high-risk disease, perhaps they have their transforming event or the BRAF V600 mutation arising very early in an early hematopoietic progenitor, where in patients with low-risk multisystem disease, it's a more restricted progenitor. In patients with a single lesion, perhaps it's a more highly tissue-restricted progenitor just for that specific lesion. All right, shifting gears for a second, we also worked with Will Parsons, who's a colleague of mine from medical school who happens to run the Human Genome Sequencing Center Pediatric Initiative here at Texas Children's, to ask the question, well, what other mutations are present in LCH? Melanoma, for example, BRAF V600E is quite common, but among hundreds of mutations. And what we were surprised to find is that in LCH, we really just found a median of one somatic mutation per LCH samples. That puts it among the least mutated pediatric neoplastic disorders. When we looked into patients who didn't have BRAF V600E, we were perhaps not surprisingly, but at the time surprised to find recurrent mutations in MAP2K1. And since then, multiple other groups have found the same thing. And what we find is that basically almost all LCH lesions have at least one driver mutation in a MAP kinase pathway gene. So in the cases where we didn't find an obvious mutation, we've used other methods to look more deeply, and we found BRAF fusions, we found these BRAF indels. And now we really have a reason for the MAP kinase pathway to be activated in almost every case of LCH. We're up to about 90%. And about 10% of the cases, we're still not exactly sure. So I just wanted to take this model and look at a few clinical cases that I think are relevant. So when we look at skin, for example, why do we sometimes get this presumed self-resolving skin LCH, where in other cases, it's really part of a multi-system disease? And so we took our patients at Texas Children's and found a couple themes. One theme is it took a while for these children to be biopsied, so over 3 months in most cases. And in cases when skin biopsy was positive, frequently it would be assumed that they had skin-limited disease when that wasn't the case in about 50% of the time. When we looked in at the age of the patients with skin-limited or multi-system disease, we found that the patients with truly skin-limited disease were in fact younger, but you can also have multi-system disease at a very early age. And whether or not the rash is present at birth also determines whether or not you have is also independent of age. But what we did find was associated with age was whether we could find circulating cells in the peripheral blood of patients that had the BRAF V600E mutation. And so in patients who had skin-limited disease, we almost never found BRAF V600E in the blood, but in patients with skin as part of multisystem disease, we in fact found BRAF V600E in a large number of cases. And so we really think this may be a model where when you have multisystem disease, it's a bone marrow or a hematopoietic progenitor, where if you have skin-limited disease, perhaps this is a wave of fetal derived epidermal Langerhans cells. And as the patient gets older, those cells just sort of burn out and aren't replaced. Okay, looking at the central nervous system, I think is another really interesting example. And so here's a case of a patient who has that LCH-associated neurodegeneration I discussed. And you can see his handwriting is almost imperceptible in panel A. And after Dr. McLean started trying to treat these patients with cytarabine, he saw improvements. In this case, you can see significant improvement in the handwriting. Historically, brain biopsies have been really scarce, and the biopsies that have been published, the few cases by Nicole Groyce and others, really just found some CD8 positive T cells, but didn't find any evidence of LCH within the neurodegeneration. And I think some new examples shed light on why this happens. And so we have 2 cases of LCH-associated neurodegeneration here. In one case, we have a whisper of CD207 positivity. In the bottom panel, we don't. But in both cases, what we see is V600E or VE1 positive staining really diffusely through the area of neurodegeneration, again, suggesting that the LCH neurodegeneration is driven by a clone of systemic LCH. Here's a case of a tragic case of a young boy who died of neurodegeneration. You can see his MRI findings on the right, where you have his T2 hyperintensity in cerebellum. His pons and brainstem were highly involved, whereas frontal cortex wasn't involved quite as much. When you look on the left, that's the percentage of BRAF V600E positivity. And you can see by the black line, 13% of his brainstem was composed of BRAF V600E positive cells. Similarly, almost 10% of his pons, a high percentage of his cerebellum, where very little of his frontal lobe and temporal lobe had V600E positive cells. When we looked at CSF of patients who have neurodegeneration, we almost never found BRAF V600E positive cells in the CSF, although in 2 cases we did, and those were cases where they actually had BRAF V600E positive spinal cord lesions. However, when we looked in the blood of patients who had active neurodegeneration, in a significant fraction, we were able to find, in patients who had no other systemic disease. On the right, you can see we found patients who had BRAF V600E positive cells in the peripheral blood, along with having active neurodegeneration. Jennifer Pekarsik is a pathologist in Cincinnati who we worked with to take these images, and you can really see these, I think, highlight a story where you have a blood vessel and then some concentrated BRAF V600E positive cells surrounding that blood vessel. They're also CD33 positive. They have markers of CD163, which is a microglial marker. What they lack, however, is P2RY12, which is present on yolk sac-derived microglia. So we really think this is a story where we have hematopoietic cells that are infiltrating the brain and driving neurodegeneration. And you can see here in a series of 4 cases, and this is published, so you can look at it in more detail in the publication. But all of these, in 3 out of 4 patients, we had a significant clinical and radiologic response to MAP kinase, or to MAP kinase pathway inhibition with vemurafenib. In 1 case on the right, we did not, but you can see this patient had active disease for 10 years and had very little healthy brain left to respond. And so we think that neurodegeneration really is driven by, again, a cell that's carries BRAF V600E that has the capacity to go to the brain and drive neurodegeneration. So taking all of this, how do we improve outcomes for our patients? So the current standard of care is vinblastine prednisone based on the Histiocytosis Society protocols. But if you look closely at the LCH3 outcomes, even though survival is pretty good in this cohort, frontline therapy cures fewer than 40% of patients with multifocal high-risk LCH. And I think we can argue we really need better therapies. And so how do we do that? Is it better chemo? Is it longer chemo? That's not exactly clear. What LCH4 is asking is, does 2 years improve outcomes versus 1 year of vinblastine prednisone? And that's based on the observation in LCH3 that 1 year of vinblastine prednisone had better outcomes than 6 months in a specific cohort of patients. There's very little published to help us guide therapy once a patient fails. I think there's various publications of nucleoside inhibitors that demonstrate success, but it really depends how much. So low dose 2-CDA, low dose 2-CDA results in very little progression. I'm sorry, when you give low dose CDA, a lot of patients respond, but as far as achieving cure, only 3% of patients were cured by 3 months. By comparison, high dose 2-CDA in ARC is highly effective, curing 100% of the patients that don't die from treatment-related toxicity. So you can see here the progression-free survival, the 30% of the patients who didn't make it to 6 months died from therapy-related toxicity. So we now favor cytarabine at moderate dose and clofarabine at moderate dose for second-line therapy, as this can be given outpatient relatively safely, and we have relatively high response rates, though studies are really needed to determine what's the best therapy. We're running a local trial here comparing frontline cytarabine monotherapy to frontline vinblastine prednisone given according to LCH, the LCH3 protocol. So we'll need 120 patients to detect a 20% difference, and we're about, I'd say, a quarter of the way through that trial. Just one other thing to think about for the hematologists in the group, we used to use hydroxyurea for several myeloproliferative neoplasms, and until we got inhibitors that was used for CML, et cetera. And I think that's a reasonable therapy for LCH. In fact, we've tried it on some adults who either don't want to take IV therapy or are not responsive to IV therapy. And you can see that we have a pretty reasonable response rate in this series. And I think hydroxyurea is something that should be considered for the right patient and perhaps to be tested as maintenance therapy. And you can see here's a patient who had cytarabine, clofarabine, multiple relapses, but then prolonged hydroxyurea really cleared up her bone lesions. Okay, going to the next slide. So what about MAP kinase pathway inhibitors? I think I've talked about MAP kinase pathway being activated in all cases of LCH. And so if you have a hammer or if you have a nail, why not use a hammer to try to cure it? And I think what we've seen really largely pioneered by adult hematologists is that vemurafenib is highly effective in achieving responses in LCH. And so the French group led by Julien Hiroche published the first series of this showing that 100% of his patients had PET responses at 6 months. But this isn't without some toxicity. So 6 out of 6 had severe side effects, and even one of them developed a squamous cell carcinoma. The Memorial Sloan Kettering group did a follow-up study as part of a basket trial and showed that only 6 out of 14 had responded to vemurafenib. But when you looked at PET response, that really was 100%. And so this slide really summarizes a lot of the most recent adult trials. And if you look over on the right, what you really see is a theme of somewhere between 80 and 100% of the patients responding to MAP kinase inhibitors, whether it's vemurafenib or a MEK inhibitor. I will point out the LOVE study that Julien Hiroche pioneered. So after 2 years of therapy with MAP kinase inhibitors, he stopped giving MAP kinase inhibition to his patients. 75% of those patients relapsed within the first 6 months of stopping therapy, even those with complete responses. So I think it's a little bit of a cautionary tale that while this is effective, it doesn't appear to cure the disease. I just wanted to point this study out that came out in Nature from Eli Diamond in the Memorial Sloan Kettering group, where he treated all adults with histiocytic disorders, regardless of histology, with MEK inhibitor, and had a very high response rate. And based on this, with just 17 patients, the FDA gave cobimetinib breakthrough designation. So we'll see what happens with that. There's far fewer cases in pediatrics to look at. In fact, until very recently, there were just a few case studies, but it appeared that vemurafenib was in fact effective in the few cases. As part of the North American Consortium for Histiocytosis, we looked at a series of 21 subjects with a variety of exposures, median age of 7 years. Median treatments have been 3 prior therapies. And even in this really hard to treat group, we had an overall response rate of 86%. But one question we asked was whether we could correlate peripheral blood BRAF-V600E with responses. And when we looked at patients treated with inhibitors, that in fact was not the case. There seemed to be no correlation with disease response and the ability to detect circulating blood cells that carry the mutation. The French group organized a continental series with Europe looking at vemurafenib, and you can see the Donadue study here really shows really impressive results in patients with high-risk LCH who failed vinblastine and prednisone. Again, these patients were only treated with vinblastine and prednisone. They all responded very nicely, but then you can see the reactivation rate was really quite striking once therapy was stopped. So I think the message is that this therapy really is effective, but it doesn't appear to cure patients. So a question we're hoping to explore in the Children's Oncology group is, does MAP kinase inhibition improve the ability for chemotherapy to be effective? So some kind of combination therapy is something we'll be exploring in the future. And so a question is, is this mission accomplished? Is MAP kinase therapy good enough? But I think there's some more targets out there. I think there's some biology studies that point at directions we can go. So for example, in the study from Mira Murad's group that we collaborated on, she demonstrated that there's very little proliferation within LCH lesions and even within bone marrow precursors of LCH. But what happens is these cells get stuck within the lesions and they just don't die. They express really high levels of BCL-XL and appear to resist apoptosis. But that sensitivity to apoptosis is restored with MAP kinase inhibition. So could this be some kind of myeloid ALPS? I know that's not a great term. I think another thing that's underexplored is looking in the microenvironment. So checkpoint inhibitors are expressed on LCH, but whether or not the checkpoint inhibition plays a role in therapy is something we need to evaluate. For adult hematologists, I think it's important to understand that LCH, Erdheim-Chester, and other histiocytic disorders can arise as part of clonal hematopoiesis, and looking for other mutations and approaching LCH as an MPN is something to consider. So after all of this, I just want to kind of summarize my thoughts on LCH, where back in the 1900s, we just saw these patients with interesting disorders, but couldn't really categorize them. Under the microscope, the biopsies look the same, so it's called histiocytosis X. Once the Burbitt granule was discovered, there was a hypothesis that the disease arose from epidermal Langerhans cells, so we're back to LCH. And then based on some expression studies and other studies, it looks like this disease, in fact, does not arise, at least in most cases, from epidermal Langerhans cells. And so how do we get here? We really have histiocytosis XYZ. And I think a couple of things that we should consider is really reframing LCH as an inflammatory myeloid neoplasia and really kind of placing it more appropriately within the WHO classification. There's been some discussion, which I'll defer to my pathology colleague later to talk about some new proposals for lumping, splitting, and shifting based on molecular and clinical factors. And then just get to discussing, again, more therapeutic options. I think in the last 10 years, what we've realized is we don't have to use empiric kind of roulette wheel or luck to figure out how to treat these patients, but we have a lot of targets in addition to MAP kinase activation of hematopoietic precursors, what's the right chemotherapy, what are opportunities for targeted therapy, and eventually we want to get to personalized therapy for these patients. So I apologize for starting late and running long. There's a lot of people involved in this work. Just wanted to just briefly thank, and thank you once again for the opportunity to share these ideas. I look forward to our discussion.
Thank you very much for a really nice and extensive review for starting from cell of origin until treatment and targeting therapy. We'll go now through some clinical cases. Maybe you can help me with what to do with those next cases. So let me just share my screen. Okay. So we'll start with case 1. So he's a 45-year-old male who presented to local hospital with bilateral leg swelling and pain slowly growing for over a year. Initially ignored, and the pain was so severe, so he has to be seen and evaluated. He didn't have any other complaint, fever, GI or respiratory complaint. So he was examined there and showed bilateral leg swelling below the knee, around 8 by 8 centimeter. All lab were within normal. So they did an X-ray and showed bilateral proximal tibial masses on both legs. So they had an MRI which showed bilateral tibial sharp diffuse bone marrow abnormality with focal sharp cortical defect and soft tissue lesion, mostly cystic in nature. And they're suggesting eosinophilic granuloma to be considered an advice for a biopsy. So an ultrasound guided biopsy confirmed the diagnosis of Langerhans cell histiocytosis. So he was initially referred to orthopedics for an evaluation. So they did an extensive CT, chest, abdomen, and pelvis, and showed that bilateral infiltrative renal disease with possibility of bilateral adrenal gland, diffuse omental disease, large liver with homogeneous enhancement, spleen as well, raising the possibility of involvement. He had a small pericardial effusion. They did a PET scan initially. They did a choline PET scan, not an FDG PET scan, and showed those other lesions, they were not FDG avid. However, those tibial and proximal femur were FDG avid, and they reviewed the pathology which was done at local hospital, and it was consistent with Langerhans cell histiocytosis. They did another biopsy from the other side. So they also consistent with Langerhans cell histiocytosis. The sample was sent to my clinic for BRAF mutation, which came back as wild type normal. So he was referred to hematology for, since it's a multisystemic disease, for treatment. So he was seen by a hematology, and he was evaluated by one of my colleagues, and he was started on a high-risk protocol in April 2017, all familiar with, which is induction with weekly vinblastine and a steroid. Then after 6 weeks, will be shifted to the maintenance form. So repeated PET scan after 3 months showed improvement of those FDG avid disease. Repeated PET scan 6 months showed persistent disease. So the decision at that time was made to extend of therapy for another 5 months to complete around 12 or 14 months of therapy. However, at the end of therapy, he presented with found to have elevated creatinine of around 340. So they did a CT abdomen, which showed further enlargement of the kidney and perinephric fat stranding, representing progression of his Langerhans histiocytosis, and also bulky adrenal disease. Repeated PET showed worsening of his tibial lesion. That was around 14 months from starting his LCH protocol. So we decided to admit him, and then he had a bilateral nephrostomy tube, then start normalizing of his creatinine. So the question now is what to give next. You know, after the first line, there is no standardization, so what to give next? So there was so many options to give single agent cladribine, cytarabine for 12 months, low dose, or just an aggressive form. So since he has an aggressive disease, a poor response to therapy, progress while almost on therapy. So we had an experience with 2 patients received those protocol with multisystemic disease. They went into complete remission for more than 3 years. So we decided to go for this protocol, which basically what Dr. Carr has said. So we start with an induction with 2 cycles of cytarabine and cladribine, followed by another 2 cycles of cladribine. Then we do evaluation, and depends on what response. Then we decide to give, if he had a complete response, we go to maintenance. If he had a partial response, then additional 2 to 3 cycles of cladribine. And then we go for, we call it intensification of 6 months of vinblastine, 6 mercaptopurine methotrexate, and another 1 year of maintenance of 6 mercaptopurine methotrexate. So total of 2 years of therapy. So PET scan few months after that showed good partial metabolic response, and patient improved. His creatinine has normalized, and he has no more leg pain. We did 7 months later another PET scan, which of still persistent this osseous lesion, which was both biopsy from the right and the left persistent with SUV max of 8.6. So at the end of therapy, they showed slight disease progression of new focal increase FDJ on the left tibia as well as the right, with slightly disease progression. So the question comes now, what you give? So he's a wild type BRAF. He had the LCH protocol. He had the high cytarabine, cladribine protocol, finished 2 years almost. So what to give next after that? So the patient is feeling well. So at that time of the COVID-19, he said, I want to take a break. I've been taking therapy for almost 3 years now, so give me a break. We decided to repeat it. PET scan is coming in 2 weeks. So, but the question is what to give next. So, any suggestion, Dr. Carl Allen, for this case, what to give? So one of the colleagues suggested, since it's those TBL, can we give a radiation therapy for him? What do you think?
So yeah, that's a great case. I think that case summarizes so many of the challenges in treating adults with histiocytic diseases. 'Cause you end up with all these partial responses, and it's I'm actually surprised how well he seems to have tolerated pretty intense therapy. And I think that you could do a couple different things. I mean, I know some of my adult colleagues. I'm a pediatric hematologist. Some of my adult hematology colleagues now are going straight to MAP kinase inhibitors for this kind of a patient. And even though the pathology is described as LCH, having the tibial lesions, having kidney involvement, having possibly pericardial involvement, it really sounds a lot like Erdheim-Chester disease. And so it would be interesting to stain those biopsies with macrophage markers and see if maybe it's a mixed disorder. It would also be interesting to look in his bone marrow to see if this is part of clonal hematopoiesis or there are other things going on. But having said that, I think that, again, like you said, there's nothing really to guide therapy, but I think it would be reasonable to try a MEK inhibitor if that's available. If a MEK inhibitor is not available, I think that probably we would try clofarabine. For some reason, we see responses in clofarabine when we don't see responses in other nucleoside inhibitors, and it's given at a dose that's tolerated relatively well, even can be given outpatient.
Okay, so I'm gonna see him next month after his PET scan, so we'll go over those options. So just for the sake of time, we're gonna go for case 2. So he's a 19-year-old, was referred from pediatric team. So he was diagnosed 2007, so 6 or 7 years when he was, with Langerhans cell based on biopsy from his large humerus lesion on the right side. So he was treated with vinblastine, prednisone for 1 year, went into CR for almost 12 years. So he went into CR for 12 years. Then in March 19, presented with pain at the same site of the previous diseases, which is an X-ray done. And if you can see here, there is this lesion. So they decide to do a bone scan, which you see here, there is an uptake on the right humerus, some mild faint uptake on the distal end of the femur. So he had an MRI which demonstrated large lesion 9 by 6 centimeters. So this is the official report, like 7 by 1 by 1.4 centimeter lesion on the MRI. So bone scan and MRI all said characteristic of LCH. The PET scan also shows some small activity, the same areas where the bone scan, and the same the MRI, the right humerus. So now we try to go for a core biopsy from those lesions. So 2 core biopsies that just showed some fat and some, it's not a diagnostic for anything. So we had an open discussion with the patient and the orthopedic, and they said it's an open surgery. He would require a bone graft. It's a large lesion, so high risk of fracture and bone graft. So now the decision is what to do, to treat based on same lesion relapse at the same site, based on MRI and PET scan or not. So this is a really question what to do. So we had a meeting with orthopedics, with radiologists, and with his pediatrician who treated him, and then we decide to treat him. But would you treat based on those, or would you insist on having a biopsy?
That's another really fascinating case. It's pretty unusual to have a relapse after that period of time, which would make, if the story was this came back 6 months after his initial therapy, I would presume it was LCH and say that second biopsy was not indicated. But I mean, looking at that image, it's hard to imagine kind of what else it might be, and it sort of depends what you have in mind for treatment. I guess the importance of getting a biopsy. It seems like something that might be worth another try with interventional radiology, and if it's possible to do BRAF V600E qPCR, that might be sensitive. But in cases where we have like C1 lesions or again, other lesions that are just not possible to biopsy, we have treated patients empirically and then just repeat imaging in 2 to 3 months. And if there's a response, a positive response, we presume that the diagnosis was correct. But, if it's not getting better, then the unlikely possibility this could be a different malignancy or infection or something else would probably justify the risk. You mentioned radiation previously. So I think radiation isn't particularly, we don't typically use radiation for systemic disease because we think it's hematopoietic derived, and you may end up with new lesions. That's the one case where we'll sometimes use radiation as if it's a lesion that's difficult to get, and it's a single lesion. But in the setting of a relapse, I think I would approach this more as systemic therapy, and we'd probably treat a patient like this with cytarabine or clofarabine.
So I think, thank you. Now, without any further delay, we'll go to Dr. Ghaleb Alyamani. He's a consultant hematopathology at Prince Sultan Medical City who has an interest on histiocytic disease. So Dr. Ghaleb, you can unmute yourself and share your screen. Dr. Ghaleb?
Yeah. Do you want to continue? So my screen is clear now or not? Hello? My screen is still not?
No. So you have to share screen.
Share.
So now, yes.
It is okay now?
Yes, now it's.
It is clear?
Yes.
So it's clear?
Yes, it's
clear. Okay. Good evening, everyone. First, thank you for SSPD for gives me opportunity to share our diagnostic channel in histocytic disorder. This is my disclosure. As we know, histocytic disorder are a group of diverse proliferative disorders that occur when there is an overproduction and infiltration of histiocyte or mononuclear phagocytic cells to the tissue, causing tumor or organ damage. Based on this type of the cell, there is 3 groups of histocytic disorder. The first group is dendritic cell disorder, with the most common one is LCH. This group also includes juvenile xanthogranuloma and Erdheim-Chester syndrome. So second group is macrophage cell disorder, which include primary HLH and residual disease. The third group is malignant histiocytosis, which include certain type of leukemia and malignant tumor. We'll go very fast as time is very limited, and also Dr. Carl give us a nice review about this one. For histocytic disorder, have a wide variable clinical presentation, ranging from single implant lesion to multi-system affection. Usually the diagnosis is challenging due to rarity of the disease, clinical overlapping with many other conditions, in addition to lack of awareness among physicians, as this case usually went to the other, not hemo-oncology, usually go to the primary physician, rheumatology, orthopedic, which is not familiar with this disease. So diagnosis usually depend on clinical presentation, imaging, and the pathological finding. So the first case scenario today is 36 years old male with no relevant past medical history, presented with chronic diffuse bony pain, mainly around knee and elbow joint, with on and off generalized pruritus. This complaint presented for 4 years with progressive worsening, especially in the last couple of months. He developed blurred vision and the exophthalmos and the diffuse and the difficulty in walking. The second, please. So the patient went and investigated in multiple hospitals with different subspecialty with no definitive diagnosis. The patient received during this journey of 4 years analgesia, vitamin D, topical steroid, antihistaminic, and for pruritus when flare up. He referred to our hospital. On admission, the lab result unremarkable with the exception of mild thrombocytopenia and the mildly elevated CRP and ESR. So the patient went to a radiological investigation. So this is the radiological investigation of both knee and the humeral bone. If you look carefully about this one, you will see diffuse sclerotic changes around the knee in the femur and the tibia. And also in the humerus, you will see intramedullary sclerosing with the proximal end of ulna and tibia. And this is go more clear picture magnification, diffuse sclerotic changes around the knee joint. More you see very clear with high resolution. Okay, again, also intramedullary sclerosing with ulnar tibia affection. So due to this finding in X-ray, we go further for the bone scanning, PET-CT, MRI, and CT. So bone scanning is technician show with PET-CT show in the left panel of this figure, diffuse bilateral symmetrical increased uptake in the long bone, in the lower limb, in the humerus. See also in the right clavicle and also in the mandible and the maxilla. So if you go also MRI show increased enhancement in the pituitary region and the retrobulbar this area, and the increased by PET-CT increased uptake also in pituitary and retrobulbar soft tissue uptake. Also fuse PET-CT and CT show increase uptake in perinephric tissue. MRI and CT show in intramedullary sclerosis changes. So also bone scan show clear increase in symmetrical uptake of the radio translucent uptake of long bone, also block to the right clavicle, to the mandible and the maxilla, and also tarsal bone. So I think with the clinical feature of diffuse bone pain for a long time, with characteristic radiological and PET CT, and we have high possibility of histiocytic disorder characteristic for this one. I think everyone can, we say, is there is any need to more further work up for this patient for diagnosis? Yes, the answer is yes. So accordingly, CT guided biopsy from left proximal tibia was performed, and you see what we have. So this is a low power of H&E diffuse infiltration by mononuclear cells, have abundant cytoplasm, oval or rounded nucleus with some background lymphocyte. We'll go to maybe high power. If we look to high power, now we have a foamy histiocyte. In addition to this one, we have a foamy histiocyte. Look to this cells, which is multi-nucleated giant cells called totem giant cells. So we have extensive infiltration by mononuclear cells, have a specific feature discussed before. We have foamy histiocyte. We can go more and more. We see more totem multinucleated giant cells, totem giant cells. We have background fibrosis, the streaming of the cell. Now for pathologists, I think any you will think about histiocytic infiltration with multinucleated, with increased giant cells, with increased fibrosis. We think about more histiocytic. So we went to more immune state to confirm this histiocytic lineage. We do CD68 is positive. We do CD1A is negative. Langerhans, which is CD207 is negative. S100 is partially expressed and weak. And factor 13 is positive. And finally, 163 is strongly positive, which is a histiocytic marker. Now, I think now we have histiocytic finding of what's called with Erdheim-Chester syndrome with characteristic radiological feature. Okay, so now, so diagnosis is confirmed with Erdheim-Chester syndrome. Now we will see this guy, went for multi-subspecialty with 4 years journey to diagnose this issue. We just summarize it very quickly, and he is suffering from, and he referred to us in the late stage after exophthalmos, after eye affection, after pituitary gland, after liver. So it came us very late because there is no one think about this disease, especially in early disease, which is very important issue. Plain X-ray can miss the finding of X-ray. So this is very important issue for physician. In early stage, X-ray cannot miss the sclerotic changes and this one, which is a very important issue for clinician. So I will go. I think I am not going to discuss all issues to time limit, but Erdheim-Chester syndrome usually 95% of patients presented by bone pain, which is the commonest presenting. There is other extraskeletal involvement like eye, skin, lungs, CNS, as seen in our cases. For sure, in such a case, we have a differential diagnosis. One of the top differential diagnoses is Langerhans histiocytosis, which is excluded by negativity of CD1A and the Langerhans also. Also, RDD should be excluded as a histiocytic disorder. Wegener granulomatosis, multiple sclerosis, Paget disease is most top differential diagnosis. But fortunately, the characteristic imaging study is very characteristic for Erdheim-Chester syndrome. So other differential diagnosis, there is a long list of differential diagnoses. The most important is the first, the briefest one. So this is, we have 3 systemic histiocytic disorder of adult Erdheim-Chester syndrome, LCH and RDD. They can differentiate it based on immunophenotyping, but unfortunately, there is another which is usually common in pediatric, which is juvenile granuloma, has the same feature and the immunoprofile of Erdheim-Chester syndrome, but can be differentiated based on the clinical presentation. Also, I'm not going in details in this table. I think it is available and published in Blood. Can go for more details. So second case is 11 years old girl, initially presented to our hospital and complaining of severe back pain post-trauma, is falling down on her back. Patient was seen in ER by spinal team and radiological work-up is performed. Okay, so chest CT and the abdomen, no gross abnormality. Skeletal survey detect lytic lesion at the pedicle of the 8th vertebrae. Whole body PET CT confirms there is right 8 thoracic spine pedicle lytic lesion. So this is the CT of the spine. See in the right side, there is a osteolytic lesion and the compressed fracture in the transverse process of the 3 in this area. This we did PET CT confirms there is metabolic active lytic lesion in the same side of the fracture, in the same side in D8, but there is no other side detected in the whole body image. Okay, we did CT guided biopsy. We get this biopsy, and the low and the high power side. Look to the right side of the image. We will see the same. Maybe we have the same picture, diffuse infiltration by mononuclear cells, rounded or oval nucleus, abundant cytoplasm. There is some inflammatory background, eosinophil, lymphocyte, plasma cell, but there is no, not like previous one, there is no phemohistocyte or there is no multinucleotide cells. So one of the differential diagnoses of histiocytic disorder, lymphoma is still one of the differential diagnosis. Other malignancy like whatever, all are put on our consideration during the manage this one, but this the morphological feature of the first impression of histiocytic disorder. We did CD68 and the CD1A, as we see, both are positive. We did S100 and Langerhans, both are positive. So the diagnosis is straightforward. It is Langerhans cell histiocytosis. So this patient, as it is single bony lesion and there is no other lesion in this patient, only single lesion, and due to critical site, our team in pediatric hem-onc decided to give this patient only local chemotherapy, radiotherapy. So after 3 months, we did PET CT again. If you remember the first one, there is no hair increasal uptake in the previous one at the baseline. This is the post-therapy after 3 months, exactly after 3 months. Okay, so after and the patient stopped treatment. After 3 months of the index therapy, the patient come back again with complaining of right hip joint. MRI done again. There is showed small cystic lesion involving posterior aspect of the right femoral neck and extended to the greater truncal. This is the MRI of the hip. Shows cystic lesion here in the femoral neck. We did again PET CT, increase the uptake in the same area in the neck of the femur up to greater truncal. So this patient, if we collect all the PET CT at diagnosis, this is the picture at diagnosis. See, there is increase in uptake here in the lytic lesion. After 3 months, the lytic lesion is disappeared or recovered. This patient, there is no increased uptake. But at baseline, there is no uptake here in the hip joint. But post therapy, after 3 months, the patient came back with relapse at this area, with increased uptake in right hip joint. Again, we take neck. This is my question to Dr. Omar. We need to do biopsy again or treat it as relapse, because the patient is coming within 6 months or couple of months after treatment with relapse. This is true. I think I agree with Dr. Carl. We have to do biopsy if it is available. We already have available site. We did core biopsy with the same morphology. When the diagnosis come back again is Langerhans histiocytosis. Our team in pediatric came labeled this case as relapsed LCH and started chemotherapy. And now the patient is ongoing therapy and for assessment later on after a couple of weeks for PET-CT.
Okay, Dr. Ghaleb, 2 minutes.
Okay, this is my conclusion. Histiocytic disorder and still we have cases, but it's okay. Time is limited. Okay.
Okay. Thank you very much, Dr. Ghaleb. Now we have a few questions for Dr. Carl. So Dr. Hind Salam from our National Guard colleague asking about bone marrow transplant. So what's the role of bone marrow transplant?
That's an excellent question. I think our thoughts on bone marrow transplant are sort of evolving, and we haven't quite settled on when the optimum time and what the right patient is. Clearly, for some patients, BMT can be curative. There are some national series that demonstrate that patients who are transplanted for LCH and related disorders, I think do experience some bit of treatment-related morbidity and mortality, and that can be because so many of them are treated with so many different cycles before going to transplant. And I think also the ability to achieve good clinical response with MAP kinase inhibitors is sort of limiting the number of patients who go to transplant. But having said all of that, I think if you have a patient who really has evidence of persistent disease that's clinically significant, transplant is a reasonable option, especially if they're a good transplant candidate. I think one area where I've seen that we can be tricked is patients who have good responses with like vemurafenib monotherapy, for example, and then go to transplant will sometimes relapse because I think, again, they haven't really achieved a CR prior to going to transplant, just as sort of a cosmetic CR. So again, that's an excellent question. Unfortunately, there's not a huge amount of data to guide transplant in adults. I would kind of approach these patients similar to other patients with myeloid neoplastic disorders associated with clonal hematopoiesis as far as risk and benefit. And then again, for that specific patient, maybe if available, maybe try a MEK inhibitor first and see if that is helpful. And if not, again, I think this is a patient where maybe hydroxyurea could be, maybe could play a role once there's clinical control with either an inhibitor or other chemotherapies.
So she's asking, do you have any preference with conditioning regimen like you?
Yeah, I mean, I think that it's I don't specifically. I think that there's some good reviews out there that kind of show what's not super surprising, that patients who have reduced intensity conditioning tend to have less treatment-related mortality, but more relapse compared to patients with myeloablative conditioning. And I believe in the most recent meta-analysis from CIBMTR, the outcomes were basically equivalent, somewhere around 70% overall survival. But I'd have to review that paper to remember for sure.
So one is asking, is any specific precautions you've done with patient or chemotherapy during COVID time?
Yeah, I mean, that's a great question. Everything's turned upside down with COVID. And I think patients with LCH and other histiocytic disorders are kind of similar to all of our other pediatric oncology patients, and I think the biggest issue we're finding is sort of getting difficulty with access. People are presenting late, challenges with non-urgent diagnostic biopsies, et cetera. I think that's all much better now than it was 3 months ago, but I'm unaware of any disease-specific risk for LCH patients compared to other cancer patients. Now, your own group has sort of shared a really interesting case of a patient who developed HLH secondary to COVID, which I think it probably is a phenomenon that happens. But I think that the case that you shared with me is really well described, and I think that would be the one kind of histiocytosis specific complication to consider is if you have a patient with new onset of HLH, certainly I think COVID is worth investigating.
So I have a question about, I'm sure you have most experience with Erdheim-Chester. So what's your first line? You're still using interferon, or you've moved to vemurafenib for those with BRAF positive? You know, I have a few patients with poor tolerance to vemurafenib, severe hand and joint pain and swelling. And so do you still use vemurafenib as a first line or still interferon as a first line?
Yes, so again, as a pediatric oncologist, I don't personally treat a lot of patients with Erdheim-Chester disease. We do give advice sometimes. You know, I think one thing we've heard from Julian Haroche and Eli Diamond, who are fantastic resources, if you need to reach out to people for help with Erdheim-Chester, is that lower doses of vemurafenib seem to be effective in patients with Erdheim-Chester. So if you're having severe toxicity, I think stopping therapy, taking a little drug holiday, and then restarting at a lower dose sometimes can be effective. And then also, if you have access to MEK inhibitors, that can be effective. And I've also heard of cases where just kind of switching between the different BRAF V600 inhibitors sometimes can improve tolerance. But that's a tricky area. I think that, I mean, clearly some patients responded to interferon and do respond to interferon. I think there's some debate in the community whether one should consider MAP kinase inhibitors frontline for these really challenging patients, or whether one should first try cytokine therapy and then use MAP kinase inhibitors as second line. I mean, I think the results of empiric MEK inhibitor therapy are pretty compelling, although it's a very, very small series. And you know, the more we can treat patients on study, I think the better the community will benefit from these experiences.
I don't know if Dr. Ghaleb has any question want to ask, or
yeah, I'm really wonder. Yeah, I read the nice article for Langerhans histiocytosis in New England Journal of Medicine before, with the first speaker is Dr. Carl Allen. He mentioned the Langerhans histiocytosis in pediatric is equal to Hodgkin lymphoma in pediatric. I'm really, because we are here in Saudi Arabia, we didn't found a lot of cases for Langerhans histiocytosis. Yeah, I think we have only a couple of cases in our hospital. If we compare to the pediatric Hodgkin lymphoma, we have a lot. Every month we have maybe a couple of cases in pediatric Hodgkin lymphoma. At least every month we have one case. So regarding, is this maybe related to geographical and epidemiological difference, or what?
Yeah, that's an excellent. Yeah, that's an excellent question. So I think it's probably a couple factors. One is I think that not all these patients make it to us. Sometimes they get biopsied by dermatology and are presumed to have skin-limited disease, or maybe they'll be treated by orthopedic surgery, and so they're not concentrated like Hodgkin's patients are. But I think another thing is that there clearly is differences in ethnic background. So we see about somewhere between 2 to 4 as frequent LCH in patients of Hispanic background, which we so it's kind of overrepresented in Texas, for example. We almost never see, so in our series of about somewhere between 1,200 and 1,500 LCH patients. I think only in our local series that we've kept over the last 10 years or so, only 10 or so of them are African or African American. So I think there's some interesting implications of genetic background that we still don't understand. So yeah, so we'd be very interested in your local series. In fact, one of my colleagues, Aaron Peckham, we're working on looking at the different mutation rates in different ethnic groups. So if anyone's interested in collaborating with us on that project, please shoot me an email. I'll be delighted to add you to the study.
So one question is, so one asking, a relapse refractory extensive intracranial and spinal juvenile xanthogranuloma with BRAF wild type failed clofarabine, cladribine, cytarabine, and radiation therapy. What would you recommend?
So I'm sorry, I'm just reading the question. Yes, that's a really challenging case. I mean, I think for juvenile xanthogranuloma, Rosai-Dorfman disease, we've seen a lot of these cases respond to clofarabine. So we really typically start those patients with clofarabine just because, again, there's not enough data for great evidence. So that, please take my comment with caution. But yeah, so if patients fail clofarabine, I think that moving to inhibitor therapy would probably be our next move. And even if you don't have a definitive mutation, I think that it's probably worth trying the MEK inhibitor for a couple months and see if you get a response.
There is a report about dasatinib for those juvenile xanthogranuloma, like low dose dasatinib. Do you have any experience with this?
I don't. I think that it kind of depends where the mutation is, right? So I think that I mean, there certainly are some cases of ALK mutated juvenile xanthogranuloma, Rosai-Dorfman disease, and even LCH. So I think whether you could use like imatinib or different BRAF inhibitors or MEK inhibitors kind of depends where the mutation is. And I think the rationale for using MEK inhibitors is that you'll capture the majority of mutations because there's really only rare cases of mutations in ERK, for example. So it depends a bit what's available.
I think if we have no more question, we can conclude. And I would like at the end to thank Dr. Carl Allen for his nice extensive review presentation, and Dr. Ghaleb Alyamani for also his histopathology review. I really thank you, and please for the other attendee, join us on other MENA program monthly on interesting diseases. Next one will be on 28th of September about Waldenstrom macroglobulinemia. And also at the end, I would like to thank our sponsor, Janssen and Hikma, for their support. Thank you very much.
Thank you.